Hi, everyone. Thank you so much for joining us for Health Impact Assessment, an overview. We are SOPHIA, and we are the community of HiAP, which is Health in All Policies practitioners. Health Impact Assessment is one of the many tools of Health in All Policies, and this is the first in our four-part series on Health Impact Assessment today. As I mentioned, SOPHIA is an association of individuals and organizations that provides leadership and promotes excellence in the field of health impact assessment and health in all policies. We are a community of folks who do this work or who are learning to do this work across the spectrum of professional life cycle. And we also build resources that make those available for the community. You can join SOPHIA for a very low fee of $50 at hiasociety.org. And I encourage you to join SOPHIA. Our other sponsor today is the George Washington University Sustainable Urban Planning Program. This is a 48-hour master's program at George Washington University focused on training the next set of leaders to address the emerging threats of climate change through the built environment. I am going to be your host today. I am Sandra Whitehead. I am the current president of SOPHIA, and my day job is that I'm assistant professor and program director at GWSUP, as we call it. My background in this work is that I did my graduate work in public administration and public policy, and really focused in on how infrastructure impacts health and equity of the residents who either do or do not receive it. And from there, as I was going through grad school, I worked as a local government planner. And through that work was introduced to a very basic kind of health impact assessment, working with local governments called PACE-H, which is the protocol for assessing community excellence in environmental health. And through that work began this journey of wondering, how do we consistently assess the impacts of built environment policies specifically, but also other kinds of policies and regulations on the long-term health and equity of the people who are impacted by them. And really, after doing that work for about 15 years and working directly with 3 different communities, I moved to the Florida Department of Health, where I was able to do this work on a larger scale, working across the state. And my mission was to help the county health departments really think about health and equity in a different way, and help them create products and tools that they could apply in their context. And HIA was one of the very first tools that we use. And I did that work for about 9 years and really developed this training model and this community building model of practitioners that I apply in my work at SOPHIA. And you are the beneficiary of some of that work and experience today. I moved to DC to work at national nonprofits to replicate that model across the United States, working with health departments. And during that time, I joined the National Environmental Justice Advisory Committee for a council for EPA, where I started working on cumulative impact assessment. And I know a lot of you on this call are also interested in that topic. But this is where my research and my community experience collide, in that now I'm applying all of those things that I've learned about HIA and health and all policies, and really applying them with my students and to my research. You can use the chat during our talk. I have everyone on mute, but if you have questions as we're going through, please put them in the chat and we'll address those once we get through the formal part of the presentation. So thinking about why you might want to do a health impact assessment, you really have to think about, from a health public health professionals' perspective, health impact assessment has primarily been practiced at local health departments. And there are so many factors that influence our health that are outside of their control. And it's outside of the control of any regulatory agency as well. So thinking about the social determinants, right? The things that make us able to live a healthy life, right? Our health behaviors, our physical environment, which is where a lot of my work has come in, right? How do we make sure that people have clean water, clean air, and safe land? How do we make sure that they have transportation choices and that their transportation around them isn't killing them? Right. And then there's the clinical care, which is only about 10% of what makes us able to be healthy or not healthy. And then this very much larger piece of social and economic factors. Whether or not someone in the family has a job is the highest predictor of whether or not the family has health insurance, for instance. All of these factors work together to create our physical and mental health. But health departments didn't always have tools, right, to work on those. So HIA is one of these tools that they can use to not just address long-term, the root causes of long-term health outcomes, good ones and bad ones, but also to influence equity through working with other agencies. So thinking about how policies, and I'm using policies with the small p, because policy with the small p encompasses not just laws and regulations, which is policy with a big P, but also plans, right? Like community plans, comprehensive plans, procedures, like how do you do your everyday work? How does a permit get issued? How does zoning get changed? And then programs, larger programs of projects. And those actions of government help make people able to make healthy choices. You know, in public health, we say, well, we want to make the healthy choice the easy choice. But in this work, we have to make the healthy choice the possible choice first. And HIA is one of the tools that helps us do that, to insert health implications into these other sectors. To give an example of policies that create these disparities, right? You know, housing policy drove a lot of the white flight and changing policy around urban renewal and redlining and the Federal Highways Act, right? This is more and more of the disparities that were driven by these root causes in these policies are coming to light, and we need more tools to address them, not just you know, the harms that have been caused in the past, but the harm they're still causing and that cumulative piece of the harm. So what exactly is an HIA? An HIA is a systematic process. It's a 6-phase process that's very well outlined. It uses different data sources. Usually it's a mixed methods approach because we want to make sure that we're addressing lived experience and engaging with communities. And it really is very heavy on community and stakeholder input, and not just to, you know, of course, you do a literature review and you present what the impacts are, but also to hear from people who were impacted, the people who live there, who experience this every day, and what their impacts are. It might be something that doesn't come up in the data. So it's very important in this process to make sure that you're engaging regularly with the community. And the other piece that's really important is that an HIA looks at one of the P4s before it happens. So it is just in time to influence the decision before it's made, and to provide recommendations, not only how to address the positive and amplify the positive health impacts, but to address and ameliorate to the extent possible negative impacts, and to monitor and manage those over time. So it's a quite a dense definition, and you'll see as I go through some of the definitions what it means. So as I said, it's a 6-phase process, and we use the term phase instead of step because it's iterative. Just because you've gone through the scoping phase and you think you have everything, as you're engaging with the community, things might change as you get more information. So you will revisit the scope from time to time. And this is true of some of the other parts of the process as well. So we use the term phase because it is iterative and recursive. You're going to go back sometimes as you get more data, and it opens up more avenues. And it just depends on how much time you have and how much community engagement you're doing during your process. And really, it explores the impacts and how it disproportionately impacts vulnerable groups, and not just how it impacts vulnerable groups in real time, but over a span of time and over a span of geography. So it's not a static snapshot of what might be the issues today, but also over time. So it can also include broader issues like those socio-economic issues, like climate change and other things that haven't quite happened yet. So it's different in that way from a risk assessment. And it makes recommendations to maximize health benefits and minimize risk to the extent possible. And there are things that can be done, and a good example is if you're finding there's a disproportionate impact around air pollution, for instance, maybe a risk minimization strategy would be to plant trees around, say, the school or the daycare centers, so that it creates an evergreen screen to the extent that you can protect the folks, the children inside. So that's one example. And then there are guiding policies for the practice of HIA. These are enshrined in SOPHIA's founding documents and in the minimum elements and practice standards for HIA. Democracy is very important, and making sure that community voices are heard in the process, that the people who are impacted by the decisions are included in creating the solutions, and that they have a role to play in prioritizing which things get addressed and which things don't. Equity, the whole purpose of looking at health impacts is to create a more balanced decision-making process so that equity is considered, and making sure that disparities are addressed. And, equity doesn't mean everybody having the same access to resources. It means that the people who have less access to resources are brought up to the same level as everyone else. So whenever you're making sure that you're addressing especially distributional impacts and distributional equity through the environmental through the HIA process. And then sustainable development, making sure that the recommendations are focused on protecting people in the future as well as protecting people in the present. Scientific and robust practice. I know I've had people who were, hard scientists laugh at me whenever I say this before. And what I mean by, because they didn't think that qualitative or lived experience was real evidence. But really what this is saying is that we are transparent about the evidence that we're using, and that we are using the best data available to us, both qualitative and quantitative, and that we've blended these in a way that represents the priorities of the community, right, and their lived experience. And that we've collected that data in a robust way so that it's defensible. And then a comprehensive approach to health. This says, when I talked about using the social determinants of health approach, where we're looking at all 4 of those boxes whenever we're looking at HIAs. And then this holistic approach where we're thinking about health not just as the absence of disease, but as this whole sense of well-being. and how to address the whole person. A lot of health assessments do not look at mental health, do not look at community engagement, community health and how people are connected to one another. HIA opens those avenues to look at things like social connected and to do social analysis, network analysis. And it uses a wide variety of tools, is my point. So a lot of people say, well, what distinguishes this from a health assessment or a risk assessment? A couple of things. It's proactive. I mentioned earlier that HIA is looking at something that hasn't happened yet and predicting health impacts. And you always have to talk about your level of certainty or uncertainty, the level of likelihood that these are going to occur. But it's important that this happened before, that decision makers have this decision before the final outcome. And it's really a framework that can be used to translate data into policy plans or projects that have been community driven and community approved, community owned, if you will. And it's not an advocacy tool. I've seen people say that it is, but it really is not. It is a way to expose possible implications of a policy plan or project. And it's not an evaluation. You don't do this after the decision has been made. And as I said, it includes some aspects of risk assessment in the assessment phase, but it's not a traditional risk assessment as it's done by federal agencies. And then, so why would you, oh, sorry, did not mean to scroll forward. So why would you want to do an HIA as opposed to using some of the other tools? It's prospective. It increases transparency in the decision-making process. And it supports inclusive and democratic decision making. It's a tool to advance equity and justice and address disparities. But it also works on this quality of life framework that I think isn't always apparent in scientific analyses, especially human health analyses, right? It can look at things like future earnings lost or years, not lived or income not earned for a family, but it also looks at stress levels and, community stressors that are non-disease stressors. And it can facilitate better decisions and better implementation at the community level. As I said, HIA also brings together a lot of different stakeholders, right? It's not just the people who live in the community, it's also people who own homes in the community, people who are landlords, people who own businesses in the community. These are all of the stakeholders that come together. And it acknowledges that there's trade-offs and choices. It says that you can't take away all risk, but here are some things that you can do to decrease risk. And it would have maybe an offsetting equity imbalance, but HIA gives you a chance to put those on the table and to talk about those with the people who will be impacted and for them to co-create these trade-offs, not just for it to be dictated to them. There are a lot of different kinds of decisions that have been influenced by HIA over the years. The first HIA was conducted in the United States in 1999 in San Francisco. It was looking at the implementation of raising the minimum age, not the minimum age, the minimum wage. And it was done by the San Francisco Department of Health. Over the years, HIA has spread across the United States. As I mentioned earlier, it's primarily been adopted by public health departments. But depending on which region of the United States you're in, HIAs might have been conducted by community-based organizations, which is very very much prevalent, much more in the West Coast and the Pacific Northwest, or public health institutes might have been the partner. That's true in Kansas and Georgia to a large extent. And there's different kinds of topics that they've looked at, and I've just given you some examples here on this slide. And the map here is from an HIA that was done on a comprehensive plan looking at the distribution of land uses and where the locally unwanted land uses wound up in terms of population and population distribution and health. So it was pretty interested in informing their policy on their comprehensive plan. But HIAs have been done on such a broad variety of things. I actually consulted on one in Nevada that looked at whether or not children under the age of 7 needed to go to school, because they weren't required at that time to do so. And this one was done by the Southern Health District of Southern Nevada, that did that one. So it's a very flexible tool and it's a very scalable tool. I mentioned that there are 6 phases and that they are not, I have a straight arrow here, but it's really just a decorative arrow. It would be too messy to put the recursive arrows. But these are the 6 phases. Screening and scoping are where screening is whether you're deciding whether or not an HIA is even feasible, something that you can or want to do. Scoping is really when you're designing the HIA and what will it look like, how long will it be, what are the parameters. An assessment is exactly what it sounds like. It's assessing and making a plan to address the health impacts that are predicted. And then reporting is not just reporting back the recommendations to decision makers, but also reporting out to the broader community of what the results were, what the recommendations were, so that it's not just the participants who are holding decision makers accountable, but the broader community. And then your monitoring and evaluation. Evaluation is exactly what it sounds like. It's the different kinds of evaluation that you do to make sure that your process and your outcomes are valid. And then monitoring is looking at your recommendations over time to see what the outcomes are. So I'll go over each of these a little bit more in detail. As I mentioned, in screening, you're really deciding whether or not the HIA is doable. So is there enough time to do the HIA between now and the time you decide to do it and the time the decision needs to be made? Because you want to make sure that the information and the community engagement information gathering that you're doing is useful and in time for the decision to be made. There's nothing more frustrating to a community to go through a big long process and get it to the decision makers and they say, oh, we made our decision. We released our report last week. Thanks so much for your advice, right? So you need to make sure there's enough time. Is it a decision where they're already considering health? Is health a criteria in this decision? So if we're talking about a regulatory decision, say a rezoning, are they thinking about health outcomes whenever they're looking at their rezoning criteria, say for an industrial use? Maybe, maybe not. If they're not already, maybe this is a valid thing to do. Do you have enough resources to complete the HIA? Do you have not just enough time, but do you have dedicated staff time? Do you have the right kind of staff? Do you have enough data? Do you have enough time to gather the data if you need to collect primary data? What does that look like? And then making sure that you've clearly defined the decision to be informed. Making sure that you understand all of the context of the decision, where information can be influential, and how to frame the information, the results of the HIA such that it can be useful to the decision makers. And sometimes that's as simple as the word choices that you're using. And sometimes, like instead of climate change, saying interannual weather variability, or maybe it's the kind of outcomes that you decide to look at or how you measure those, right? So in one HIA that we did, the way that we had to talk about climate change was we had to talk about the financial impacts to businesses and to restaurants along the coast and to infrastructure for local government. That was how the decision makers were going to be able to hear the information. So that's how we had to convey it. And then who are the decision makers? Is that clear? And then the last and probably the largest consideration is it politically useful to conduct the HIA, right? You don't want to go and do an HIA on a project and have just something else is more important than that, right? So look at your timing, look at who's making the decision, and then you can decide go, no go. Scoping, which arguably is the most important part of the HIA process, is really whenever you're deciding what does the HIA look like? What are our goals? What are our research questions? Who are the stakeholders, right? Who's not just who's impacted, but who are the secondary and the tertiary stakeholders, right? Who's going to implement this decision? Who are the adjoining landowners that'll be impacted, right? So making sure that you understand the geographical boundaries of the impacts. If we're talking about something like air pollution, it's not just one jurisdiction, right? You have to know how the wind blows and you have to look at the models. If we're talking about, underground water pollution, it could be quite different, right? So making sure that you understand the geographical boundaries of the impacts and who's impacted and getting a preliminary idea of what the impacts are and how they're related to the policy or the project that you're assessing. And that's called the pathways. And then the time frame. What time frame do you have not just to do the HIA, but what time frame is the decision going to be made in? How do you line up your process time frame with the decision time frame and the community input time frame, right? Because you can't just do that stuff overnight. So making sure that you have all of the five interrogatories answered as you're thinking about your project. Right, you have to decide what are the limits in the scoping project. Who's going to be disproportionately impacted, who's most impacted, who's peripherally impacted, and what kind of HIA should be performed, right? How deep do you want to look into it? The great thing about HIA, as I mentioned, is that it's scalable. So there are four basic kinds of HIAs, and there's all kinds of permutations of this, but these are what I think of as the distinct kinds. So desk-based is if you don't have a lot of time or if you don't have a lot of ability to do community engagement. A desk-based is doing an HIA based on what you can find sitting in front of your computer. So that might be systematic reviews, that might be other studies, it could even be other HIAs that you could use to inform and formulate what the health impacts might be of the project that you're working on. A rapid is a little bit more time than that, usually 4 or 5 weeks, and you are not still looking at a ton of impacts, usually no more than 3, but you have time to do a little bit more of a deeper literature review and to think about the potential health impacts with some community assistance and really thinking about the way that you would engage, a lot of times it's just having meetings where you're sharing information and gathering information. And then your data collection is really limited. You might do some interviews, maybe some small stakeholder guided interviews, but it's mostly, desk-based plus a little bit more. And then an intermediate, which is what most people think of whenever they think of an HIA, is where you're taking about, 6 months to do the HIA, and you're looking at maybe 3 to 7 impacts. I've never seen one with 10 that was an intermediate, honestly. And you're going through the assessment in a really robust way. You're looking at qualitative and quantitative data. And you might even collect some primary data from stakeholders during an intermediate. You have a lot more stakeholder engagement and interaction. In an intermediate, you would have a community advisory board made up of people who are impacted, people who are secondary stakeholders, and then people who would be implementing the decision. And then in a comprehensive is about a year long. And these look at as many potential impacts as possible, because you have a lot of time to spend with the community in a comprehensive, and you're able to do a really deep dive into their lived experience, into their actual health outcomes. In a comprehensive that we did in Naples back maybe 6 or 7 years ago, we actually did short health interviews. We had a community health nurse from the health department come out and do short health histories with residents, because they kept maintaining that the pollution was causing them long-term health impacts. And so we were monitoring that. So, I mean, there's a lot more you can do whenever you have a lot more time, but usually, especially in a regulatory time frame, you almost never have a year to do an HIA. And thinking about, the value of community voice in HIA is, they are able to contextualize the decision and their experience for you by voicing not just their historical, but their current health and environmental concerns. What the data told me one time, whenever I went into this community in Daytona Beach, the data told me that their issue was walkability and obesity and asthma. And when I got there, what they told me was that their issue was flooding. Right. So the data doesn't always tell you accurately what the community should be most concerned about. Right. That's the fallacy of researchers. Sometimes we come in and we say, here are your problems. HIA doesn't do that. And it also is able to give people a platform to talk about equity issues that maybe they wouldn't feel comfortable with in other settings. It increases the transparency of the process and the decision making. It allows you to ground truth your findings, as I was saying, right? To say with the community, here's what we found looking at the data. Does this ring true to you? Does this feel real to you, to your experience? And if not, let's talk about that so we can address this broader range of things and co-create these recommendations. And then it increases the support whenever you're able to do this broad community engagement, increases the support and the accountability around the recommendations and getting them implemented. And what I think is one of the best outcomes, though, is that HIA gives communities practice and helps to build their capacity to participate in decisions, not just these kind of decisions, but other governmental decisions that impact them. What came out of the first HIA that I ever did back in 2012 was the community form their health equity action team. And they were able to not just get more walkability, to get attention to their community, but to get a highway that had bisected their community fixed, to get a road diet on it so that their children can cross the street again and go from their homes to school, which is just incredible. Scoping, whenever you get done with the scoping process, you should have a statement of the goals of the HIA, a description of the impacted population and the geography, like where do they live. You should have your research questions, and I recommend not more than 3, otherwise it becomes unwieldy. And a list of people participating, what their roles and responsibilities are. And this is more of a stakeholder map, right? Who's impacted, who's got a stake in it, and then who's on the periphery of the decision that will be concerned. And then a draft pathways diagram or logic model, which maps the relationship between the decision and the health outcomes. And it's a really good tool so that when you're working with your community, it is apparent to them which things are influencing their health and what it looks like. The next phase after you've done with your scoping is the assessment phase. And this is really whenever you're taking evidence and you're looking at the baseline data, you've already decided, what you need to look at, what are the important factors that are present in the environment and the context as your baseline. And then you are using various assessment ways to predict the outcomes, the health outcomes of the decision. That might be using a literature review and using preponderance of evidence that exists in the literature. It might be, as I said, talking to community members. It could be looking at data and analysis of a similar project and what those health outcomes were. The really great thing about HIA is that mixed methods approaches are built into it. And so it really just depends on what your question is, what kind of assessment methodology that you would use. But the assessment methodology should result in characterization of the impacts, their likelihood, their direction, whether it's severe, positive, severe, negative, maybe a little bit, right? So how many people? And it's, excuse me, the intensity and I'm trying to, sorry, and the recommendations around it. So here's what one would look like. The health outcome is obesity, and the decision was looking at an additional fast food restaurant in a low resource neighborhood where there's already a lot of this. So they were looking at obesity. They decided that new fast food restaurants would negatively impact obesity at a high rate within the population, right? So it would be a lot of people, it would impact them greatly, and the likelihood that it would happen is high. So their distribution, they're showing as low income residents who were affected more. So that's just an example of what that would look like. This is one outcome of an assessment process. The reporting phase is where you are reporting the findings of the assessment phase and the recommendations that you have co-created with your community members back to the decision makers, to the larger community, so that you have input and transparency to them. And usually there's, a report. It doesn't have to be a 200-page report. I've seen reporting mechanisms be things like an executive summary or a video. There's a really great HIA where they reported their results in a video. It was of this law in the Pacific Northwest where they were going to outlaw mobile homes along the coast. And it's a really great video. But it could also be like this meeting in Pinellas County, where the staff went back and reported the findings to the community in a setting like this. And then what was really great about this particular meeting was once the presentation was over from the partners who had done the HIA, then we set up these easels, which you can see over in the corner, and we worked on an implementation plan, right, with the community. with their feedback. So that leads me to the next piece, which is evaluation. And in HIA, because the outcomes, the health outcomes are usually so far out, something like obesity is really hard to measure in the short term or to attribute to a particular intervention. So many times we are looking to process evaluation in HIA primarily. And we're also looking, because we do have a standard, we have a minimum elements and practice standards, which are on the SOPHIA website, and were just updated last year. And it really says, here's the criteria that says this is an HIA. Here are the things you should have done in each of the phases that make this an HIA. Did you think about this? Were you transparent with how you did things? Did you talk about your limitations? Right. And so the minimum elements in practice standards really gives a guide that practitioners can use to assess their HIA work. And it also gives them a guide if you're just starting out, right? It's kind of a step by step. But in the process evaluation for HIA, you can look at, because you've set out your goals in the very beginning in the screening and scoping phases. So you can say, did we accomplish our goals, right? Did we use our resources well? Were we inclusive, right? And there are measures, they're not in the minimum elements, they're in my paper, but there are measures on inclusion around, did people feel heard? How are you doing your community engagement? Did people feel engaged? Do they feel like their recommendations will be used? All of these kind of process measures that you can look at as you go along and improve throughout your HIA, so that when you get done, you can look at those process measures over time. As I mentioned, outcomes are really hard when looking at health outcomes, but you can look at other kinds of outcomes. What new partnerships were formed? Um, did the immediate health impacts that you predicted occur? How well were community concerns incorporated into the ultimate action or the ultimate decision that was made? And is there any ongoing community involvement, any outreach from the decision makers back to the community? And then in the early days of HIA, people would go, they would say, here's my evaluation. I'm going to go to the decision makers and I'm going to say, did this HIA make any difference? Right? Did the information that we brought you, did that change your mind? That's not very effective. But if you can look at after the implementation has gone through, you can go back and look at how many of the recommendations were adopted, how many of the community members are able to remain engaged. Did the process change because of the HIA? Were health considerations institutionalized in any process change? So these are the kinds of evaluations that you can look at for HIA. But I think where the rubber really meets the road for HIA is in this monitoring phase. It's after the HIA has been done and you've given the decision makers the information, they've made the decision, then who's accountable? Right? So monitoring on the back end usually is what you get during the process is you write a monitoring plan. And in the monitoring plan, you try to account for surveillance of outcomes over time that you predicted in your HIA. You want to try and evaluate the effectiveness of the recommendations that were implemented at either, amplifying positive health impacts or ameliorating negative health impacts. And if you're doing your monitoring in 1, 3, and 5 year increments, you can actually go in and make new policy recommendations to tweak the process to be more health protective or health promoting. And your monitoring plan should include an indicator for each of your outcome of interest. There should be some agency that's assigned to monitor each piece of the plan and report back. The group should have a meeting scheduled to come back together. And there should be defined what I think of as toll gate health points as triggers. So if, pollution increased instead of decreased, or asthma related emergency department visits went up instead of went down when you predicted they went down, there's an indicator that you can use to go back and say, we need to re-examine this. We need to reopen this. And that, I think, is really the long-term range impact of HIA. Yes, there are challenges, especially with monitoring plans, especially with evaluation. By the time people get to evaluation and monitoring, a lot of times in the HIA process, they don't have resources to do this part of it, or their grant has run out and it's not required. And so this is really the weak point, I think, of implementation. In the idea stage, in the process, and laying out the process, I think it could be really strong, but there has to be support for it. And there has to be institutional support for the people who are doing the HIAs to do that long term. So I'm going to stop the formal presentation part of this and see if there are questions in the chat. But I do want to encourage you to join SOPHIA if you enjoyed this webinar. We do have 2 others coming up soon. On June 7th, past president of SOPHIA, Dr. Katie Hirono, will talk about her dissertation, which was on community engagement strategies in HIA and how that impacts power and participation over time. And then we have part 2 of this HIA series on screening and scoping on June 15th. That link to register is not yet up, but we will have it coming up soon. So I'm going to unshare.
So Sandra, we had a couple questions in the chat. One was, what are some examples to collect robust qualitative data?
So focus groups where there are guided questions, there's been training, and you have a really good way that you've laid out of analyzing the qualitative data from something like a focus group. I find that works much better in small groups. So that's just one example. And I will say that that's probably probably one of the more common pieces of qualitative data that's used in HIA, making sure that you're able to understand people's perception, because so many times, the data will tell us one thing, but what their perception is, that's their reality, and you can't discount that, and you have to address it.
Great. There's another question. What is your target audience for the evaluation?
Usually it's other HIA practitioners, right? I mean, honestly. But it should be yourself and your team, right? Because everybody's really competing against themselves. Whenever I evaluate my HIAs that I've done, what I try to do is identify places where I didn't do such a good job, and I could address that in my practice for the next time, or I could work with the community group on helping them shore up this, this area of it that could have been stronger. But I mean, usually it's to improve your practice.
Great. Another question about transportation projects. Many transportation projects are years in the making. Doing an HIA when the project is already developed may not be able to reshape previous decisions. Do you have any suggestions for early action or complementary actions?
Yeah, one of the things I used to tell people that I train to do this work, if you really want to work on transportation or land use planning, you have to make buddies with those people, right? Like, you have to go over and be friends with them, or you have to watch the advertisements in look where they're advertising for consultants to do this kind of work. Because you're right, once these things are on the drawing board and they've put pencil to paper or AutoCAD drawings down, it's really hard and really expensive to change it. So getting into those processes very early, what before design, preferably, but making sure that you have a connection with the people over there in those offices that are doing those projects. I think there's no replacement for getting the early heads up. And so much of it is person dependent, but I hate to say that, but it's true. It's relationships, right? It's health and all policies.
Yeah. Another question is, what's the best practice for ensuring low resource community participants, like people with limited access to transportation or internet, hear about the findings of the HIA?
Yeah, for one thing, I mean, and I can't stress this enough, but meet people where they are. Host the meeting in their community, provide transportation if people need transportation, provide stipends if at all possible. And this is something that recently has changed for at least one federal agency where they're able to provide stipends for community members who might have to take off of work or, pay childcare. One of the things that we used to do is this is going to sound funny, but I used to find a local restaurant that would donate the food, and I would have community meetings in the community so people could walk. I would get the local teenagers to provide childcare, and we would feed people. We would just feed everybody that wanted to come, whether they contributed to the meeting or not, because that's how you build trust and that's how you get people to talk to you. So I think that there's some of that.
Free food. Noted.
When you can, one time we had a
Yeah.
mariachi band. That was great.
Oh, that sounds fun too. I don't see any other questions currently in the chat. Does anyone have any other questions before we wrap up? And we'll be sharing the slides and a recording of the webinar early next week. We'll get that out to everyone.
Well, thank you all so much for coming and for your interest in HIA and SOPHIA. I highly encourage you to join SOPHIA if you're not already a member, and you can do that at hiasociety.org/join. Thank you so much, and I look forward to seeing you all at a future event.